Thanks, Mike, for the introduction, and also thank you actually for inviting me to come and speak here. I'm very honoured to be here in front of you guys. So I'm a radiologist, not a radiation oncologist. There is a difference there. So a radiologist primarily will look at your scans, report your X-rays or ultrasounds or MRI or CT scan, whatever, PET scan as well. And you don't usually meet us. You know, we're sort of just a name at the bottom of the report. You don't see us. We're cooped up in a dark room usually while we look at computer screens and report your scans. Every now and then, you do have contact with radiologists, so interventional radiologists. These days with my treatment, I see patients, so I have a consult. As opposed to a radiation oncologist, who is a specialist who delivers radiation to any part of your body. Okay, so they're very different to us. So they don't report scans, but I work very closely with them because we look at scans together and then we decide what's best for the patient in terms of their management. And then there's medical oncologists as well, so that's another specialty again. If you're in the prostate cancer sphere, you know, the common sort of specialists you're going to come across will be urologists, medical oncologists, radiation oncologists, and maybe radiologists, and nuclear physicians sometimes as well. Okay, so today's topic is going to be, YK gave me 20 minutes, like there's no way I'll be able to go through all this in 20 minutes. So it's going to go on a bit more than 20 minutes, but we can have a break if you want. But I promise, you know, we'll be done probably before 8 o'clock, okay? So it's going to be a radiological and therapeutic journey in prostate cancer. There's a lot of grounds to cover, so we're going to have to skip through some stuff quite quickly, but I'm happy to take questions at the end if you have any. All right, let's go. Okay, so what's the scope of the problem here? Prostate cancer is common. So in New Zealand alone, we're going to diagnose about 4,000 men with prostate cancer this year. Okay, every year, about 4,000 men are diagnosed. And out of everyone with prostate cancer in this country, about 600 to 700 men will die of it each year. Okay, so not quite 4,000 because a lot of men actually don't die of prostate cancer. They may live with it for quite a long time, or they may be cured of it with surgery or radiation or various treatments that's available. However, for a certain subset of men, this cancer does kill, it will kill you. And some minority kills very quickly, so it can be very lethal. And how does that compare with other cancers that are common in this country? So lung cancer is the biggest killer in this country. 1,800 people will die from lung cancer every year. Colorectal is about 1,200. Interestingly, breast cancer about 700. So I don't know about you, but I generally think Breast Cancer Foundation they get a lot more publicity about the disease than prostate cancer. Maybe I'm biased because I'm a man as well. I want prostate cancer to be up there as well as breast cancer, but it doesn't seem to be the case. You know, breast cancer gets a lot of publicity, they get a lot of traction. I think prostate cancer has still got a lot of work to do to get it up to that level of publicity. There is no official screening program, okay, for prostate cancer. Nothing official, mainly because there is nothing that's good for screening prostate cancer. You can get a PSA, that's the simplest form of screening, I quote unquote. That's a blood test and you check your PSA level. And often that's your entry into that prostate cancer journey, okay, if it's abnormal. So, most men I see, they enter that prostate cancer journey via their PSA, blood test. All starts off with a blood test. You go to your GP, you say, maybe I should check my PSA, or GP suggests that you check your PSA. It's not really a screening test, remember, so it's just kind of, they have to counsel you. PSA can be elevated and doesn't mean that you've got cancer, or it could be quite low within normal range. It doesn't mean that you don't have cancer. Okay, that's why it's a bad screening test. It's not really designed to screen people. But it will pick up anyone with potentially cancer growing in the prostate gland, okay? So high level of PSA is a red flag. Other people get in through scans, so they might have an MRI, even though their PSA might be normal, but there's a family history. Okay, dad had it, granddad also had it, brother had it, that's very strong family history. And you can go to your GP and say, gee, I've got such a strong family history, I'm really concerned. PSA may be normal, but family history alone is enough to warrant a scan, for example, to look for it. Some people will have symptoms, so actually because of where prostate cancer lives or grows, often you don't get symptoms until it's really late. So the common symptoms people think of are like decreased flow, slow flow, you're dribbling, for example, or you're getting up in the middle of the night to pee. Often they're not really symptoms of cancer. They're symptoms more of a benign disease called benign prostatic hyperplasia, BPH. It's just overgrowth of the prostate gland as we get older. And they're often the ones that cause bothersome symptoms, but they're not actually cancerous. That's good. So family history we talked about. And the last one is digital rectal exam. So that's done by your GP, usually, or urologist, if you see a urologist, where they put a little index finger into the back passage and have a feel of the prostate. Okay? And if it feels craggy or hard, then that's another red flag. But again, that's quite late by the time you can feel it. Okay? Sometimes it's small and it's at a strategic location where you can feel it, but if you're starting to feel a hard, craggy mass at the prostate gland, usually it's very advanced already. So that's kind of late as well. So let's talk quickly about the PSA. What is it that we look for when we check your PSA? So it depends on your age, partly. If you're over 50, anything over 4 is abnormal, and that's over 2 measurements, 6 to 12 weeks apart, because sometimes you can have a spurious spike in your PSA. Those of you who cycle, you're sitting on that saddle quite a lot, that can sometimes put your PSA up. So they may advise you to not cycle for 48 hours or a week before you get your PSA test. If you're slightly in the older age group, 71 to 75, anything over 10, and then over 76, over 10 as well. So that's a reflection of the fact that your prostate gland will grow as you get older. So as the gland gets bigger, the more PSA it will produce and secrete into your blood. So we have to take that into account. The fact that as we get older, the gland grows and therefore PSA also goes up accordingly, even though you don't have a cancer. Okay, it's not necessarily cancerous. Symptoms that you can get with prostate cancer: bone pain. That's bad news. If you get bone pain and we know you've got prostate cancer, that usually often will mean that the cancer's gone into the bones. It's spread. So it's metastatic, we call it. You might get blood in the urine. Again, that's relatively uncommon. And the renal failure is simply because the cancer is so advanced that it's blocked off the ureters, which are tubes that carry urine from the kidneys down to the bladder. So again, those symptoms are symptoms of very advanced disease. You really don't want to be getting those symptoms at diagnosis. So that's the problem, right? Like when we talk about prostate cancer, it's like where's Wally? Like you got to look for the cancer. It's hard to look for the cancer, hard to find sometimes, but we know it's there in some people. We just got to look for it, and we don't want to wait for those symptoms to occur before we say, okay, yeah, you got prostate cancer, but because by then it's too late. We have no cure for you. Okay, this is where then the scans come in. Because why do we scan? We want to scan because we want to find the cancer. Okay, because we don't want to wait till the symptoms come along. We want to find it before the symptoms even occur. We want to find it at an early stage so that we can at least offer curative treatments. We want to find the cancer if there's any. And if we do find a cancer, we want to find out, has it spread? Has it gone outside of the prostate gland? And if it has gone outside of the prostate gland, we need to find out how bad it is. Like, is it just one spot, or is it 20 spots? Is it so many spots you can't count? Okay. And after we get all that information, then we can formulate the best plan to manage that prostate cancer. Okay. So you see, it's crucial. Right? If we don't have the scans, we won't be able to know what stage of prostate cancer you're at, and we won't be able to know how best to treat you. So scans is basically instrumental to the management of prostate cancer. And then we say, well, there's a lot of scans you've heard of, X-rays, ultrasounds, bone scans, CT scans, CAT scans, MRI scans, PET scans. So which type of scans do we actually need? And at what stage do we need any of those scans? Right up front, we're going to discount X-ray and ultrasound, because those two I don't think they have any role really in diagnosing or finding your cancer. Okay, we'll go straight to bone scan, which is number 3 on the list. Bone scan, the good thing about bone scan is it's quite accessible. Auckland Hospital's got bone scan facility. Most of the regional hospitals will have bone scan facilities. So you can actually get the scan quite easily. The problem though with bone scan is that it's not very sensitive. So it may show up arthritis, for example, in your joints, or in your bones, in your spine. And it could be cancer, it could be arthritis, so we can't be sure. It's not very specific either, right? Just because you've got a little hotspot in the bone scan doesn't mean it's cancer. Again, and there's some stuff that it misses. So it's not sensitive because it will miss disease, and it's not very specific because there's overlap in what shows up in the bone scan. You can't tell what's what. And the other disadvantage is that it uses radiation. So you get a small amount of radiation in order to have the scan. You have to have it, because otherwise we can't get the image. So I'm not a big fan of bone scan, generally speaking, because of those reasons. But why do people get bone scans then? Well, they get bone scans basically to look for spread of the disease in the bone. So if it's metastatic, it's gone outside of the prostate gland, and you want to see how bad it is. We would do that if someone's PSA at diagnosis is very, very high, because then we think, okay, well, there's a good chance this person's already got disease that's spread outside of the gland. We might as well just do a bone scan because, they're going to have disease in the bones. You might consider a bone scan if you can't get a PET CT. Okay, Psma PET CT, which we'll come to later. That is, to me, that's pretty much like the gold standard for looking at disease outside of your prostate gland. And that's the one I would recommend if someone has prostate cancer, especially in the Auckland region. Or you might get a bone scan because you have no access to MRI. Some people, and especially Tauranga, I think a lot of people there will get MRI of the whole body to look for bone disease because they don't have a PET CT in Tauranga. So here's an example of what a bone scan looks like. On the left here, your left. So there's these 4 images here, examples of a bone scan. Okay, that's basically looking at a patient. That's the patient facing that way to the wall, and this is the patient facing you. Okay, and same here as well. Just see. Yes, these 2 are patient facing you, and these 2 patient facing back. Okay, so turn their back. So these little blob of black here, that's the bladder. That's all the activity in the bladder that's excreted there. But as you can see, there's like little red hot spots here, little dots in the shoulder joints. They're always there. That's just arthritis. And that's what I mean with bone scan. It will show up a lot of arthritis in the bones that are not actually disease. And actually, this bone scan got reported as a normal scan. So no disease in the bones. Okay. But he actually happened to be a patient in one of the trials I did about 5 years ago in conjunction with Prostate Cancer Foundation. They gave us a grant to do this trial looking at the usefulness of this PET CT. So he was one of the participants, and actually when he came forward, he was diagnosed with prostate cancer, and they all had to have a bone scan at the hospital. Came through as normal. That was the entry criteria. You had to have a normal bone scan. And so then he came through for a PET scan with us, the Psma PET scan. And lo and behold, you could see there's little dots here. This one, that one, and there's another one there. So those are actually little tiny deposits of cancer, which were not picked up on the bone scan. So he went from potentially going from, potentially can cure my cancer, I'm going to have surgery to remove the prostate gland, to having this scan here, which means that actually it's too late. You can't have the surgery anymore because it's spread outside the gland. Horse is bolted. There you go. That's those little spots there. Okay, so then we move on to a CT scan, or people call it CAT scans, or CT scan we call it. And that is, CT stands for computer tomography. And it's a really good and quick way of looking at structure inside your body. Okay? If there is a lump inside your body, CT scan will show it really well. Okay? And it's good for prostate cancer in some instances, not every case, but in certain situations it is quite useful. CT scan is probably the most common scan we do in general in the hospital. If you fell off a ladder and you come to hospital, they'll probably do a CT scan for you, look at your head in case there's a bleed there, or if you break your pelvis, they'll do a CT scan for you. Okay, so there's a lot of CT scanners in the country. CT scan is useful if we know that the disease has potentially spread and we're looking for lymph glands enlargement. Okay, lymph glands are designed to filter out cancer. It's like a little filter, it catches the cancer before it goes elsewhere. And if it is filtering a lot of cancer, it will get bigger and bigger with time, it will enlarge. So this is an example of a lymph gland that is enlarged. And the downside of CT is that the lymph gland has to be enlarged for us to see it. We can see it if it's tiny, but in order to call it abnormal, it has to be enlarged. So I give the sort of comparison between a blueberry and a peppercorn. Okay, so a normal lymph gland is about the size of a peppercorn, a small peppercorn, and if it gets rounded and enlarged like almost the size of a blueberry, which is about a centimeter in size, then that's considered abnormal. And then that's when it will alert the radiologist to the fact that you might actually have cancer in your lymph gland. So it's very size dependent. The problem then is that if the cancer has only just got to the lymph gland and it hasn't caused the lymph gland to enlarge, then you're going to be missing out on diagnosing that cancer, right? Because you're dependent on it getting bigger and bigger. But we know cancer has to start somewhere. It has to start small. And therefore, by the time it gets big, it's kind of already too late. So you wait until it gets bigger. We want to pick it up when it's just tiny so that we can deal with it. So the advantage of CT is it's quick and simple, easily accessible. We can get it by just about anywhere. It's really easy to access. But then it's rely on the size, and again, it uses radiation. Okay, so some people don't like the idea of radiation, but just to divulge a little bit about radiation, let's just go off on a little tangent here. All the radiation we use in medical imaging is considered within safe limits. Okay? If you are a teenager or even younger, let's say a 10-year-old, and you're having a CT scan every 6 months or something like that for 5 years, then that might be of concern because we think a 10-year-old might live to 70, 80, 90, then there is plenty of chance for a secondary cancer to develop as a result of the radiation that's been given. But if you're in your 60s, 70s, 80s, even 50s, the amount of radiation you get from medical imaging is really not of major concern for us. Okay? The chance of you developing a secondary cancer is so remote, and the benefit from having the test will far outweigh the little chance that you might get secondary cancer. Okay, so that's what I'm going to say about radiation. Everything we do here, most of the things we do here will involve some sort of radiation, but fret not, because whatever we do in terms of the amount of radiation is small, and the risk of radiation also very, very small. So when would someone need a CT scan? So we might do a CT scan when the PSA is very high. Again, it's almost like giving up on the patient, on the man. Your PSA is really high, we're going to expect to see metastatic disease spread. We can do a CT scan. We might do it if you get on treatment and then we want to see whether that lymph gland, for example, has shrunken. So if it's shrunken, it means it's responded to treatment. That's good news. And that's easy to do with a CT scan. Just see is there a change in size from 10 millimeter to 5 millimeter. So that's good. And we might do a CT scan, for example, if you have shortness of breath during your treatment. We want to make sure there's not blood clot in the lung. So that's a CT scan, quick and easy. We can sort that out. And then we move on to MRI scans. Again, this is a major step up in terms of technology and complexity of the scan. It looks a bit like a CT scanner, but it's very noisy, very, very noisy. We usually give people headphones. You can listen to music while they're having it, but still you can hear it. And this ball here is basically one big magnet. Okay, so MRI uses magnet, and you're going to hear terms like Tesla. So before Tesla, the car came along, for us radiologists, Tesla actually means magnetic strength. So it's 1.5 Tesla or 3 Tesla, 3T. 3T MRI is what we would recommend for looking at the prostate gland because it's so small. The higher the magnetic field strength, the better detail you're going to get. So this is one big magnet. It's a coil inside, and then you run the electricity through it, and it's a superconducting magnet in here that generates a huge, huge magnetic field. And then you deliver radio frequency wave to the patient, and it gets a signal back. The physics is extremely complicated. I don't understand it, but I like the images that come out of an MRI scan. Okay. So why would we do an MRI scan? So great thing about MRI scan is it gives you amazing resolution of the prostate gland. Incredible detail, and I'll show you a picture of the prostate gland compared with CT. The other good thing about MRI scan, because it uses magnet and radio frequency waves, it's not radiation as such. Okay? So there's no concern about radiation yet. The disadvantage though is that some people are actually claustrophobic, being in this tunnel. So it's quite a long tunnel. So you can actually fit most of a person inside this tunnel. But a lot of people don't like it. It's very confined space. And some people just can't have that scan because they're claustrophobic. If you have a pacemaker, it can be a problem. Some pacemakers are MR safe. You can turn it off, for example. But a lot of pacemakers are not. So if you have a pacemaker, then everyone kind of like, maybe you can't do an MRI. It takes a lot longer than a CT scan. It will take you, for a prostate gland, for example, it will take you about 20 minutes in that long tunnel. As opposed to CT scan, you're done and dusted in 30 seconds. Okay? Not so easily accessible as CT scanner, and it's more expensive as well. So prostate MR right now will be, I don't know what the latest price is, but everything has gone up, just like everything we know. Probably around $2,000 or so, okay, for MRI. If someone has to pay for it. But the hospital has got MRI scanners. So, if there's reason for you to have an MRI scan of the prostate gland, and you don't have the means to pay or don't want to pay, hospital will do it for you for free. Okay, they've got plenty of MRI scans, so that's no problem in terms of access. So when will we do an MRI scan? We will do it when we're looking for cancer in the prostate gland. Okay, so this is the gold standard to look for cancer inside the actual prostate gland itself. Okay, and to me, it's the best form of scan, the best form of imaging modality to look for early prostate cancer, and that's the most important thing. Get it early. We might do an MRI scan again if you've had surgery to the prostate gland, they've removed the prostate, and we think the cancer's come back. Because the cancer will come back in several common areas, and one is around the surgical bed. Where they've removed the prostate gland, there's a joint there, that is a common place for cancer to come back. So we might do an MRI to look for that. And someone who hasn't had surgery but they've had radiation therapy, we might do that to look for recurrence inside the prostate gland itself. Okay, usually it's shrunken, but cancer can still come back. So there you are. This is the example of a CT scan on your left and MRI scan on the right. Okay, even like way back there, people at the back will be able to see. This is the prostate gland here in the middle. Yeah, and there's the same prostate gland right there. So you can see on the CT scan, it's just one grey blob. You can't tell anything about the prostate gland. But on this prostate gland, I can see a lot. There's different parts of the prostate gland. If it's cancer there, it will show up really nicely. And I'll show you an example of cancer on an MRI scan. So you can see the difference here, right? So one is really good to look for things that are enlarged or big, quite crude, I might add. This one here, very limited. We can't do quick scans like CT, but we're concentrating and focus on the prostate gland itself and nothing else. Okay, we're just concentrating on that. You can't do a whole body MR in 20 minutes, it would take too long. And we don't generally recommend that. So this is an example of a cancer, okay? So the other good thing about MRI is that it's a bit like many ways to skin a cat. Okay? At the end of the day, you still get your result, but for MRI, we use multiple different ways to accentuate the cancer. And collectively, they give me confidence that, yep, this is the cancer. We don't just use one thing to look for it. We use multiple different forms of looking at the prostate gland to detect the cancer. So here's one way we look for it. This is purely just looking at the anatomy and looking at the appearance, anything abnormal there. And then here's a different way again to look for that. This is basically detecting any restriction in the water motion in the prostate gland, because if you have cancer, the cancer cells are tightly packed and then the water cannot freely move, and amazingly the MRI can pick that up. So it can pick up cells which are tightly packed and there's no water movement. It will show up on that, and that often is a sign of cancer. And then the last thing we use is this one here. Again, you can see there's a little blob here, and that is called enhancement. So enhancement is when we give something called contrast that we inject into your vein, and it enhances because there's a lot of vessels in there, so it shows up, lights up like a light bulb for us. So you can see there are 3 different ways where we can look for cancer with just the MRI scan. Okay, one MRI scan. We do all this all at the same time, and there's multiple, for me when I come to look at the prostate MRI, there are multiple series or sequence I have to look at and examine in order to diagnose the cancer. So then finally we'll find Wally with that. Okay, so in the old days, like let's go back maybe 10 years. Yeah, 10 years. If you're wondering if you have prostate cancer, this is what will happen. Okay, you're wondering if I got prostate cancer, I go and see my GP. The GP will probably give you a blood test form for PSA, and they may or may not do a digital rectal exam. To me, do it's good. If you don't, that's also not a big deal because it's relatively insensitive as well. And then if either of those are abnormal, then you're going to be referred to a urologist to have the prostate gland poked, biopsy, okay? Needle to get samples of the prostate gland. And they might find some cancer with the biopsy, or they may not, because the way they do the biopsy is kind of blind actually. So they kind of just take, okay, we'll take 3 or 4 samples from the left side, 3 or 4 samples from the right side, and then send it off to the pathologist, and they try and look for the cancer that way. Okay, so they won't actually know what they know they're targeting the prostate gland, but it's pretty much random. And then if they find cancer, or sometimes if they don't find cancer and the PSA is very high, they might then go to get an MRI for you, just to see, have I missed something here, okay, with their biopsy. So that's what used to happen. And actually still happens in some parts of the country, to be fair. Okay. So sampling the prostate gland, real quick, how do we do it? I don't do it. Radiologists used to do it, but these days it's all done by urologists. Okay? If you need your prostate sample, normally it's done by urologists. So they do something called transrectal ultrasound biopsy, or trus biopsy. And they basically put a probe, ultrasound probe, into the back passage, so we can see the prostate gland. And then through here, the needle will come out and biopsy the prostate gland at various sites. Okay, so 4 on the left, 4 on the right. It's really fast. You can do it under local anesthetic, and it's relatively cheap. There is an alternative these days, which I think is better, because looking at this, you imagine this is in your back passage. This is your rectum here. You put a needle coming from the rectum, right, which, you know, you give people enema or whatever, but there's still going to be feces in the rectum. And you're basically inoculating the prostate gland with crap, or you're doing the biopsy with the needle, right? Because it has to go from the rectum and to take samples in the prostate. So you're introducing potentially a lot of bacteria in your prostate gland. So people can get quite sick from this, from trust biopsy. About 1% rate of hospitalization due to sepsis, infection, overwhelming infection from this biopsy. But these days it's an alternative which is called transperineal, and they do it through the skin instead. Instead of going through the rectum, you biopsy through here, so that you're not having to go through fecal matter to get samples of your prostate gland, which is much better. And with that, there's a very low, almost 0% risk of overwhelming infection from the biopsy. Okay, so those are the two ways that you can get your prostate gland sample. I definitely recommend the second one. So the problem with truss is can be uncomfortable. People generally don't get a GA for that, but for transperineal biopsy, sometimes you can ask for a general anesthesia. There's an infection risk, and it's effectively a blind biopsy. So this is what I mean by blind biopsy. So you imagine this is your prostate gland. There's a little slit here in the middle, that's the urine, that's where it comes through. And this is the rectum here, okay? So the needle's going to come from here, because the rectum is immediately behind the prostate gland. That's why you can feel it through the digital rectal exam. Okay, so let's say the cancer is right there at the front, and it can occur at the front every now and then. Okay, not commonly, but it does occur right at the front. So it's aggressive cancer. But this is what happens when you do a biopsy, a truss biopsy. Okay, if you didn't know what you're going for, that's what they would do. They would like just biopsy 4 on that side, 4 on that side, and try and see whether it's cancer or not. Okay, it's non-targeted, and you will miss the cancer. Okay, so that's why it's not very good. You know, if you don't know where you're going, or you don't know where you're sampling, you're going to miss it. There may be aggressive cancer in the front, and there may be a non-aggressive one. Okay? And that's quite common with prostate cancer actually. You don't just get one blob of cancer. Sometimes you get 2, 3, or bilateral on both sides. It can be multiple, and they can be of different type as well, different aggressiveness. So you could do that, and yeah, great, you got a sample of cancer, but you completely miss the aggressive one. Okay, so then you might be understaging someone. You might say to someone, oh, you got this low-grade cancer, not going to kill you, don't worry about it, we can watch and wait. But in actual fact, there's aggressive cancer as well, which hasn't been sampled. So sampling error. So a few years ago, a couple of trials, and I promise only these 2 slides will have these trials. One trial came out about 5 years ago talking about using MRI to find a cancer before you do your biopsy. Okay, so that's this trial here, Promise trial. They actually say if you have a normal MRI, you have a high probability that there is no cancer. So what does that mean then? That you actually can avoid having a biopsy. 1 in 4 actually in their group of men, a few hundred men had this trial in the UK, and they basically said, well, actually, about 20-25% of men didn't need a biopsy after all if they had an MRI. So that's great. You know, we're saving 1 in 4 men from needing an unnecessary biopsy, having an unnecessary biopsy. And then another trial came through a year later, again to do with MRI of the prostate gland. And what this trial showed is that if you do an MRI first and you saw a lesion on the MRI, then you go and target that lesion specifically. Okay, you've got to make sure you target that lesion. And if you did that, you're going to diagnose more cancer which are aggressive. We want to know that because we want to know what's the worst case scenario in the prostate gland. And if you did that, you're going to diagnose less of those non-aggressive cancer that don't matter. Okay, so again, that's great because you want to know what's the worst case scenario, what's the worst disease you've got in the prostate gland, because that will dictate how best to manage you. Okay? So it's results that matter if you have an MRI first. So, as of this year, and I hope in the future, really what should happen is, if you're wondering whether you have prostate cancer or not, go ahead and get a PSA, do a blood test, and if you want the digital rectal exam. And if that's abnormal, then you should really get an MRI first before a biopsy. Okay, and that's what would happen in most most of Auckland now, but still doesn't quite happen in the rest of the country. If the MRI is abnormal, then of course you biopsy your prostate gland, you target that lesion. But if it's normal, you have the options now of doing nothing, right? That's 1 in 4 men avoided having biopsy because the MRI is normal. Or you could just check the PSA, make sure it comes down. Usually if you have cancer, the PSA keeps going up. Sometimes if you cycle too much, it gets inflamed. It might spike a little bit, it might come down after that, or you get inflammation, it might come down as well. But in some people, actually, even if MRI is normal, it's not 100%. Nothing's 100% in medical imaging. Okay? There's no guarantee of anything. So about 10 to 15% of cancer will still be diagnosed with biopsy, even though the MRI is normal. Okay? So it's not 100%. We don't profess to pick up every single thing. But if your PSA is high, you've got family history, and it's persistently high, then I think that will still be reason to have a biopsy, even if the MRI is normal. Lastly, this is very dear to my heart, it's Pct Scan, so it's not about scanning animals, but it's about scanning, again, human body. PET stands for positron emission tomography, which doesn't really matter, but it's just a way of picking up radiation that come off your body. Okay? And that's an example of a PET scan. That's our satellite PET facility on Shakespeare Road. It has a slightly longer bore than a CT scan, but shorter than an MRI scan, so not such a problem with claustrophobia. How does PET scan work? So PET scan for prostate cancer has really come a long way in the last few years because of this PSMA thing. PSMA stands for prostate-specific membrane antigen. It's not related to PSA at all. It doesn't really matter what PSA is. We're talking about completely different things. PSMA lives on the cell surface of cancer cell. Okay, pretend this is a cancer cell, ugly looking thing, and let's say PSMA is that little twig or thing there. Okay, so it's just a cell is a cell membrane receptor or protein that sticks on the surface. And we can find these little proteins because they're really quite specific to prostate cancer only. Other parts of the body might have a little bit, but it's actually really common in prostate cancer to have this PSMA thing, okay, protein living on the cell surface. So what we do is we inject the patient with something radioactive. It's called gallium-68. And it's got, like, imagine that's like a male part and there's a female part. So we have a female part that's attached to the gallium-68. So that's a peptide that will find that little male part here, okay? So we inject it into your body, and this is what happens. It circulates around your body, and where there's cancer, it sticks onto it. And this gallium here continuously emits radiation that gets picked up by our scanner. And our scanner can then localize and tell me, where is this radiation coming from? Is it coming from a prostate gland? Is it coming from a lymph gland? Is it coming from the bone? Then it tells me, yeah, this guy's got prostate cancer in the bones or lymph gland or whatever. So when would you need one of these scans then? It's kind of bad news if you need one, actually. So if you've been recommended one, usually you've been diagnosed with something called high-risk cancer, high-risk prostate cancer. And that is a criteria based on the Gleason score or ISUP score. That's basically how we grade prostate cancer. The higher it is, the more aggressive it is. PSA level is very high, that's high risk. Or MRI appearance is really aggressive, ugly looking thing, and it's high risk as well. You can have the PET scan also if you've had treatment and the disease has come back. It's kind of dependent on what PSA level it comes back at. You can also have it if you're looking for treatment response, where the treatment, whatever treatment hormones, for example, is working. And also we do it if someone's going to have this lutetium PSMA as well, which is another form of radiation therapy, systemic radiation therapy that we do. So here's an example of a PSMA PET scan. Okay, so imagine this is the pelvis, and you cut this way, and like chop it up and down. So that's the front, that's the back, that's the right side, that's the left side. Head going to the wall, feet coming towards you. Here's the bladder here, it's red hot because it's excreted in the urine, so that's not cancer. But there's a little blob here on the left-hand side of the patient's pelvis. So that's an example of a lymph gland with prostate cancer. And that lymph gland probably be about 5-6 millimeter in size. Okay, so if it was just a pure CT, we never would have picked it up. But because there's color, the color just signifies lots of PSMA receptor, that protein I showed you. It's just telling me, well, there's lots of that receptor in this little lymph gland here, and that usually indicates prostate cancer as a reason. Not only that, this patient also has an area here, which is where they've removed the prostate gland, and there's a little hotspot there indicating it's come back also where they've removed the prostate gland as well. Same patient. Okay, so lymph gland and a local recurrence. So the good thing about it, it's very sensitive, very specific. If we see it like that case there, then I can be very sure about it. Say to the urologist, this is recurrence, it's come back. We don't really worry about the size too much because you can pick it up, even the lymph gland is only 3-4 millimeters. The bad thing is that it's a long scan, very complex to read. In Auckland, there's only 3 PET scanners. Okay? In the whole country, there are 6 PET scanners. Okay? So there are 3 in Auckland. We have 2 of them. And then there's 1 in Hamilton, 1 PET scanner in Hamilton, 1 in Wellington, 1 in Christchurch. That's it. Okay? So if you live in, I don't know, Gisborne, yeah, good luck getting a PET scan. Okay? So that's another thing too to consider. If you're thinking about retiring to the regions, think about your health first before you make that leap. Okay, so you're going to need more healthcare as you get older, and like it or not, healthcare delivery actually is not equitable across the country because it's very difficult to make it equitable. Very, very difficult. It's costly. It's expensive. It's over more than $3,000 if you have to pay out of pocket. But again, if you meet certain criteria, then and you're part of the Auckland region, then potentially you could get that PET scan funded by the hospital as well. So there is an avenue there, and it involves radiation too, so that's a disadvantage as well. Okay, so we've talked enough about seeing and picking up cancer. We're going to briefly touch on treating. So a lot of these I don't actually do, right? I'm a radiologist. I don't use a scalpel. I used to, but not anymore, obviously. So I don't do any of these. So, but I feel like for completeness, I should actually tell you, what are your options if you have got prostate cancer? What do they go through? First of all, they potentially could be told, you don't have to do anything. Don't worry about it. Okay? Yeah, there's some patients out there walking around with prostate cancer that we say to them, don't worry, it's no problem. It's not going to kill you. Okay? And we know that because the cancer that we've diagnosed in that patient is considered as low risk or low grade. So, and the benefit or the morbidity of treating far outweighs the actual benefit. There's actually no benefit in treating those patients. Right? So that's an example of someone with what we call Gleason 6, low risk. We normally just say we can just watch the PSA, we can do the MRI, make sure nothing's changed. But likelihood is that the cancer is not going to kill you. Okay, that's great news. If you're going to get prostate cancer, that's the one you want to get. Okay, Gleason 6, low risk stuff. Yeah. But if you are anything more than that, then we're going to have to do something. Okay, either treat with sort of curative intent. You think, okay, well, I might be able to cure you, and then you're looking down the path of having surgery, and that's a urologist's job. I'm not going to talk about how they do it, but essentially there are 3 main ways they can remove the prostate. One's called open prostatectomies. That's when they make a cut and just take the prostate gland out and join the ends. It sounds really simple, but I assure you it's not. And then they can do laparoscopic prostatectomy. That's when they put the little cameras, the little ports inside the abdomen, and then dissect the prostate out and take it out and join the ends again with the bladder. And then these days, there's robotic prostatectomy. So robotic prostatectomy doesn't mean that robots doing the work for you. It just basically means that the surgeon is sitting somewhere remote from you and doing the surgery with these controls here, and and the robotic arms are mimicking the movement that the surgeon's making at their console. Okay? So it's not a robot as such performing the surgery. The robot is controlled by the surgeon who's sitting kind of like that. Well, you're here, and the nurse is there, making sure, like, you know, whatever, making sure the cords are in the right place or whatever. And they can have a coffee while they're operating on you. So that never used to happen when I was a surgical registrar. We used to have to stand there and operate. You know. But these days, it's amazing. They can teach people. They can have a chat to people. You know, have coffee, have some snacks, whatever. You know, they're sitting there very comfortable. They're not even scrubbed. Amazing. But you know, more and more you're going to hear people say, "Oh yeah, robotic prostatectomy is the way to go." But actually, from what I know, I think there's no significant differences in cancer outcomes. So that's how well you do in terms of recurrence or how long you live. There's actually no difference between these means. But there is a better outcome in terms of length of stay, how long you stay for, because it's minimally invasive with robotic. There may be a better outcome in incontinence and potentially erectile dysfunction as well with robotic. So there's not a lot of these around in the country. I think there's one at North Shore Hospital at the moment. It's the only one in the public hospital in the country. But I know, for example, Southern Cross Hospital at Wairau has got one, Brightside Hospital at Epsom's got one, and I think Mercy and Ascot Hospital will be getting one as well at each site. So there will be more and more applications for robotic surgery. It's not just confined to prostate. There are many different types of surgery that can be done robotically as well. The downside of robotic surgery, I think the consumables are very expensive. So of course, you know, people who make the robots, like there's only one major company that makes it, Da Vinci. They will push for people to have robotic with their marketing, but you know, in terms of cancer outcome, actually there's no difference. Okay, so I think that's probably enough for surgical stuff. If you're not going to have surgery, but we still think you're curable, potentially, then you're going to see that specialist I talked about at the start, radiation oncologists. So these guys are the ones who deliver radiation directly to the prostate gland. But they also deal with men with prostate cancer in terms of, you know, trying to cure them as well. So if we deem you not suitable for surgery for whatever reason, perhaps heart's not quite up to it, or lungs not quite up to it, not fit enough for surgery, for example, and age is the other thing. You know, people who are more advanced in age, we tend not to offer them surgery because it's a big deal to have a big surgery. So we might go to something like this, which is less morbid, and you know, men who goes onto that path will be given hormone treatment, usually for about 6 months. The point of hormone treatment is basically to reduce or to block the testosterone. So either reduce production or you block where the testosterone acts, because testosterone is the main driver for growth in prostate cancer. It's like fuel, okay? Like pouring fuel into fire. You've got high testosterone level. It just makes it grow and grow, turbocharge it. So you want to block it, cut off the fuel supply, and that's what hormone does. Unfortunately, men, we all exist with a lot of testosterone in us. It makes us who we are, right? It gives us energy. We feel energetic because of it. You get muscles because of it. So imagine if you block off, you cut off that fuel supply to the prostate cancer, you also cut off fuel supply to your muscles. You start getting, you know, weak. Some people have real problems with kind of depression. You get mood swings. You start to grow man boobs. Lose your libido. Yeah, sounds familiar, right? Like menopause. That's what it does. Male menopause. Okay? And then after 6 months, they might give you radiation therapy to the prostate gland itself and completely zap that prostate cancer. And hope, fingers crossed, that's it. Like you're cured. Okay? But unfortunately, it's not always like that. It's not always a happy ending. About 30-40% of patients, regardless of what you do, surgery or non-surgery, you're going to get the cancer to come back. Okay. No matter what we do, it will come back. About 30%. In the unfortunate situation where You're not a surgical candidate. You're also not a curative candidate, and that's when you've got a disease that's spread outside the prostate gland. Then we call it palliative. So we're just trying to control the disease now. Can't cure it anymore, just trying to control it. Because at diagnosis, the disease is gone, it's bolted. It's everywhere in the body. So that's when chemotherapy comes in. That's medical oncologist domain. And immunotherapy also, that's also medical oncologist who administers that. Radioligand therapy, and that's myself and Dr. Henderson are currently the only two people administering that for prostate cancer in this country. But it's very common in Australia, very common in Europe as well, radioligand therapy. And then radiation therapy, radiation oncologists do have a role, but mainly just kind of spot welding, you know, like if you get pain here because of the cancer, they might just radiate that area there just to relieve you of the pain. Okay, spot welding, symptomatic spot welding. Okay, so because you know, this is kind of my area, radioligand therapy, I'm going to talk a little bit more about that. And so what is it? It's basically treating disease based on the biological marker. Remember we talked about the PSMA at the start, about the PET scan, you know, how it's protein that lives on the cell surface. We use the same thing actually. We use the same marker there, but now instead of seeing it, we're going to try and treat it. And the way we treat it is we use this thing now called lutetium-177. It's a heavy metal that emits radiation, emits damaging radiation actually, that doesn't travel very far, it goes only 1 to 2 millimeters. Okay, so I chuckle because one of the patients who came from Nelson to see me, he described his medical oncologist told him lutetium therapy is like having little Hiroshimas in the body. Okay, it's quite accurate. I think it's quite accurate. So she goes like, why do you want to have like little Hiroshimas all over your body? But actually, that's kind of what we do. We deliver these little radiation bombs, if you like, but we don't just bomb the whole body. We are very targeted about it. We're very specific about it. It's like having a sniper in your body, right? So now we put the same similar kind of female part, attach it to this lutetium here, and then we inject it into your bloodstream, and where there is that little protein there, prostate cancer, it's going to hook onto it. Okay, so and all that time, it's basically, and there's 10 of these, there'll be 10 of these hooked onto it. If there's 50, there'll be 50 of these attacking the one cancer cell. And it's all that time delivering little short-range radiation that is damaging to the DNA of that cancer cell. It breaks the DNA strands. And we hope that if enough breakages, the cancer cell just can't cope and just like can't repair itself and dies. Okay? That's how it kills the cancer cells. Yeah. So pretty fascinating actually. Like, you know, the theory is amazing. Like when I first heard about it years ago, I thought this is it. Like this is the silver bullet, like, for cancer, right? You know, it's amazing. But it's great for prolonging people's life. But you know, remember these men are actually kind of at the end of the journey already. Some of the men I see when they come to this treatment, they have probably 6 months to live, maybe 12, anything 6 to 12. So it's a bit sad. But you know, I aim to give them extra 4 to 10 months on top of that. And some people think that's amazing, you know, and it's, for me it's a constant reminder that we really have to cherish what we have. You know, you wake up every day, you just take it for granted. But for these men, you say to them like, look, you know, we'll probably get another 4 months out of this or 10 months out of this, and they think it's amazing because you know it's so personal to them. That 4 to 10 months extra means they potentially could attend their daughter's wedding or granddaughter's wedding. They can be there when their grandson goes to school, starts school. They can do things on their bucket list, to go on a cruise previously, before COVID hit. My patients used to schedule their treatment in between the cruises. One of my first patients actually, his goal was to be around, so I treated him early in the year. His goal was basically to be around end of the year for his daughter's wedding. And then after that I heard that he was actually last man on the dance floor. Right? So it's amazing, it's great, right? Like stories like that. The downside though, you know, by the time they get to the stage of needing lutetium, it's really just palliation, very end stage. And even though I show you that diagram where, you know, a cancer cell dies and whatever, we're targeting this thing, not everyone will respond to it. For whatever reason, some of the cancers are just smart, they're just clever. You know, even though you break the DNA strands, it will repair itself and keep growing. Okay, it's like pissing in the wind. Gee, so hard to treat. So for those men, we do a couple of cycles and it's still progressing, and we're going to say like, actually it's not working, we're going to have to stop. You're going to have to like sort out your affairs. Okay, and then what I find is that, you know, there's a variable amount of time people get after the treatment. Some of them live 3 years. One of my patients from first treated in 2018, he only just passed away earlier this year. It's like 3.5 years, amazing. But he'll be the exception rather than the rule. The rule is, even after people finish this, life expectancy around anything within 12 to 18 months, generally speaking. And it's crazy expensive. That lutetium, people who make lutetium in Europe and Ansto in Australia, they charge like a Winter Bull in China shop. Gosh. So we have to somehow pass on the cost, so it's really expensive for people to have it. Okay, we're talking about a treatment regime of about 4 cycles, somewhere between $70,000. Okay, and that's over 6 months. So it's not cheap, and it's sadly financially inaccessible to a lot of people. So here's an example of, this is a Psma scan. I'm showing you a Psma PET scan again with color. The red here, so these are kidneys, we ignore that, that's not disease, that's a bladder again, that's a spleen, that's a liver, ignore all that. But there's cancer right there, that's in the breastplate, breastbone, that's in the rib, and that's in the vertebral body, that's in the shoulder. These are salivary glands, we ignore that, that's not cancer, but this is though, this is a cancer in the skull base. But you see this guy, I treated, one of my earliest patients I treated, after 4 cycles, no, after 2 cycles or 4? 4 cycles, I think. You know, all these sites of disease all kind of melted away, they kind of get dampened down to control. And his PSA also dropped. This one here didn't respond nearly as well, so this is one to watch. Maybe that's one that's kind of quite clever already. They've adapted to the radiation itself. The rest of it is still kind of stupid and gets killed. So there you are, that's a treatment response. What we do know is that, you know, if you're able to get a response like that and the PSA goes down, we know that this patient's life was prolonged compared if we hadn't done anything. Okay, they would have lived longer than otherwise. Here's another example of a patient. You can see we're a circle here, a lot of disease in the bone. And after 2 cycles, he had a really quick response here. And after 4 cycles, almost completely gone. Amazing. And here's the pattern of PSA we want to look for, from a peak of about 60 something or 70. You know, with the treatment, I think I've got arrows here. So first cycle delivered there, PSA drops straight away. Another cycle delivered there, keeps dropping. And then we managed to have this low-level grumbling, low-level PSA. But at the end, it's just starting to flick up again. Okay, so this was 3 years ago, this patient. I think this might be my last slide, actually. Thank God. Yeah, I'm sick of my voice. So what's coming after this year? So I'm still in a campaign to get people improved access to MRI, and that's both public and private hospitals. Trying to encourage urologists in the public sector also to get an MRI before they do a biopsy. That's a work in progress, but you know, a lot of urologists are coming around to the idea because we've got those trials that show that it's good for people for men to have an MRI before they have a biopsy. I want to I want New Zealanders to have improved access to PET CT, okay? And not just people in the cities, in the big cities, but also people in the regions. So if you want to move to Hawke's Bay to retire, at least we want to get you access to PET CT. You don't have to travel all the way to Auckland for your PET scan. And how are we going to do that? Well, Mercy's going to get onto a mobile PET scanner. All right, so we're going to put one of those PET scanners onto the back of a truck, a trailer, and we're going to drag it all the way to Hawke's Bay. Okay, that's where you're going to live. We'll pack that scanner there for you. Okay, so we might drive it to Tauranga as well, if you're going to go to Tauranga, maybe Palmerston North. So that's in the pipeline, probably within the next 12 months or so. We're going to have that up and running for Upper North Island at least. And Cyclotron Auckland. So what's a cyclotron? Cyclotron is the machine that produces a lot of the tracer radioactive material that we use for PET scanning. Currently there is one cyclotron in this country, and that's in Wellington. And if that breaks down, the whole country doesn't get any PET scans done. And so that's not good enough. We need a backup. So we're also in talks and joint venture with an Australian company to try and set up a cyclotron right here in Auckland, so that we can at least supply our people in Auckland, supply Hamilton as well. They often get, they don't get their supply because of fog at Hamilton Airport. So it'd be good to be able to just move it on the road for them. Improve access to robotic surgery. I think that's going to come. The public hospitals are likely to have more and more better access to robotic surgery. And then from my point of view, improve access to other forms of radiation or the radioligand therapy as well. There are other types of heavy metal, not just lutetium, there's actinium, and there's other forms of antibody that we can match it to. The female part that we talked about, there's other different forms as well. And one of the things that we've not actually been great at is opening trials for men with prostate cancer in this country. And compared to someone in Australia, you're going to have a lot more access to different trials in Australia, partly because there's a bigger population there, they have more money there. There's more money in terms of funding these trials, whereas we don't really have much of that here. But we're actually in collaboration with an Australian company called Telex Pharmaceuticals. They're keen to set us up as a site for trials, and so we hope to bring a lot of these trials that are accessible for men in Australia to Kiwi men as well. So that'll be the aim. And I think that's my last slide. Thank you. Kia ora.